Good evening, all. Myself, Dr. Kiran Verma, working as head of the Department of Emergency, Yashoda Hospital, Malakpet. So, welcome you all for this series of webinars connected by Emergency Medicine Department, Yashoda Hospitals. Then, today we have come up with an interesting topic called pulmonary thromboembolism. So, this is third most common acute cardiovascular syndrome. First one is MI, third one is CVA, the second one is CVA. First one is MI, third one is pulmonary thromboembolism. These are the most common cause cardiovascular syndromes. So before we are going to talk about our session for today, so we have small quiz. So it comprise of 5 questions. So it is open for all the audience, all the viewers. So yeah, I request all the viewers to type your answers in our chat box. The first question, shall I start with the first question? Please note down. So what is the hallmark symptom of pulmonary thromboembolism? That's the first question. So multiple choice are like first, A, chest pain, B, dyspnea, C, hemoptysis, D, tachycardia. I repeat the question. What is the hallmark symptom of pulmonary thromboembolism? A, chest pain, B, dyspnea, C, hemoptysis, D, tachycardia. Then second question. What is paradoxical embolism syndrome in PTE? I repeat the question. Paradoxical embolism syndrome in pulmonary thromboembolism. It is just one word answer. It's no MCQs for this. Then I'm moving on to third question. What is Phlegmasia alba dolens? Phlegmasia alba dolens. This is also one word answer. No MCQs for this. I repeat the question. Phlegmasia alba dolens. Moving on to fourth question. So what is Phlegmasia cerulea dolens? I repeat the question. Phlegmasia cerulea dolens. This is fourth question. Then moving on to last question. What is PIOPED study? PIOPED study. PIOPED study. So we are done with our 5 questions. Then we will move on to our topic proper. So today's topic for discussion is pulmonary thromboembolism. To enlighten about this topic, I would like to welcome our senior most and expert and eminent ER physician who doesn't require any introduction at all. She is none other than Dr. Saujanya Patibanla. I welcome you, ma'am, on behalf of Yashoda Group of Hospitals. Ma'am, unmute, please.
I'm on unmute only.
Okay, yeah, yes,
Yeah.
ma'am.
Thank you for wonderful introduction, Kiran.
Thank you, ma'am.
Yeah. So,
ma'am, till now I have done with the quiz session.
questions you have finished, I think, right? That's what
Yes,
I have been seeing.
comprised of 5 questions. So they are going to type in the chat box. Then we'll move on to our topic proper, ma'am.
Okay, sure. And how do I go about the slides?
Pawan?
Yeah, one moment, ma'am.
I was told that the slides will be shared.
Yes, ma'am. It is there with us.
Okay. So good evening, one and all. So I will be speaking about pulmonary embolism, and Dr. Kiran has already covered the important questions for the topic already. So before I get into the topic per se, there are few critical decisions an emergency physician should be aware of while dealing with a case of pulmonary embolism. So the questions are, how should patients be evaluated for pulmonary thromboembolism? And how do we know who is at risk and who is not at risk? And the second question and most worrying for ER physicians is, what are the characteristics of a massive pulmonary embolism and submassive? So what is the difference between this massive and submassive PTE? And most of us know that there will be a right heart dysfunction, but how do we identify as emergency physicians what a pulmonary embolism with right heart dysfunction is? And how do we manage these patients in the emergency room, and what are the precautions we need to take while resuscitating these cases? And other things are, what are the appropriate treatment options for both massive and submassive pulmonary thromboembolism? So I won't go into the definition per se of what pulmonary embolism is. So it is basically the blockage of pulmonary arteries, either the main branches or its branches, occurring due to a venous thrombus from elsewhere in the body, which gets dislodged and enters the pulmonary circulation. And this causes pulmonary infarct and increased pulmonary vasculature, leading into other symptoms, and also right heart failure. So as we get into the incidence, usually there will be around 1 lakh deaths per year from US data, and 1/4 of these patients present with sudden cardiac death. So by the time we realize that this patient has PTE, there will be a cardiac arrest in these patients, and 1/4 of the patients will already have right heart dysfunction by the time they present into the emergency departments. So as we know, the usual pathophysiology for any pulmonary thromboembolism is virtuous triad. So it's a combination of hypercoagulable states and static blood flow or any injury to the vessel. So with this, we will understand what are the risk factors for pulmonary embolism. Yeah. So the risk factors can start from hypercoagulability or malignancy. So most of the malignant patients, by the time they recognize they have a malignancy, they may present to the emergency department with pulmonary embolism. So pulmonary embolism can be a first symptom in these patients with malignancy. As we know, pregnancy is a hypercoagulable state, so they will be at risk up to 4 weeks of postpartum. Increased levels of estrogen or antiphospholipid antibodies, they are at risk for pulmonary thromboembolism, cerebral venous thrombosis and all. And other genetic factors also make them prone for hypercoagulable states like factor 5 or prothrombin gene mutations, etc. Venous stasis. So this is another common symptom what we find. Those who are bedridden for more than 48 hours, or there is any long bone fractures, recent hospitalization requiring them to be bedridden for longer periods, or any long distance air travel or automobile travel are prone for causing venous stasis in the legs, which causes deep vein thrombosis, and that gets dislodged and causes PTE. And any vessel injuries like recent surgeries or endotracheal intubations, all these can cause vessel injuries and make them risk for pulmonary thromboembolism. So coming to the history of presentation, how do these patients present to us? 60% of the cases present as dyspnea. So when we say dyspnea, we should understand why these patients will have dyspnea. There will be pulmonary embolism, causes decreased blood flow to a particular area in the lungs, causes pulmonary infarct. So this causes ventilation perfusion mismatch that leads to dyspnea in these patients. So this is the reason why patients of pulmonary embolism can have dyspnea. They also can have chest pain, which will be because most likely it is a pleuritic chest pain, and because of pulmonary irritation caused by the decreased blood flow in that area. Some patients can also have anginal chest pain, that is because of right ventricular ischemia. So an anginal chest pain is a complication for these patients because by the time they present to us, the already right ventricle ischemia has happened. So the next symptom what we find is hemoptysis. Another common finding in pulmonary embolism is hemoptysis. Again, this is caused by obstruction of pulmonary arteries. As we know, there is a dual blood supply to the lungs. One is by the bronchial artery blood supply and pulmonary artery blood supply. When there is an obstruction of pulmonary arteries, there is an increased arterial supply of the bronchial side, which causes rupture of the minute bronchial vessels, which causes hemoptysis in these patients. And atrial fibrillation can be an usual presentation, onset presentation for these patients, because and any unexplained tachycardia, tachypnea, or unexplained hypoxia, you should have a high index of suspicion for pulmonary embolism. Then, so coming to the pathophysiology, as I have been explaining, embolization is the most common finding for pulmonary embolism, and that can lead to the physiological changes in the lungs and right ventricular dysfunction. We go one by one. So whenever there is a stasis of blood in the proximal limbs, that can lead to proximal leg DVT or cough vein thrombi, which gets dislodged into the circulation and ends up in the pulmonary vasculature. From the right heart, it gets into the pulmonary vasculature and causes obstruction of the vessels. That's how it is seen. This, what happens after this? So there is an increased pulmonary vascular resistance. When there is an obstruction, the resistance increases. That leads to impaired gas exchange that happens, and alveolar hyperventilation that leads to increased airway resistance. So that decreases the pulmonary compliance. So because of this, that particular area of the lung is deprived of oxygenated blood, which leads into pulmonary fibrosis, or pulmonary ischemia is first thing that leads to fibrosis. That is the reason why these patients will end up in having ventilation perfusion mismatch. Then because of this, there will be a increased back pressures that causes right ventricular failure. So what happens when there is a right ventricular failure? So when there is a pulmonary embolism, there will be acute pulmonary hypertension that leads to right ventricular dilatation. So there is an obstruction of the pulmonary vessels. So the back pressures increase that causes right ventricular dilatation. So once there is a right ventricular dilatation, it increases the contractility and myocardial stretch of the right ventricle. So the right ventricle, the pressures in the right ventricle increases beyond that of the left ventricle and causes ventricular dyssynchrony. And again, it leads to impaired ventricular filling of the left ventricle and causes cardiovascular collapse. So this is the reason why you get hypotension in the patients of pulmonary embolism. So once there is a hypotension and pulmonary embolism, that is a critical state, and we call it as massive pulmonary embolism. So let us see the differences between massive pulmonary embolism versus submassive. So any patient presenting to the emergency with acute PTE in cardiac arrest, or if the patient's blood pressure is less than 90 systolic, or the patient is requiring any inotropes for maintaining the blood pressure, we call them as massive PE. So once it is a massive PE, you have to be very vigilant and treat them aggressively in the emergency department, may need to give thrombolytics in the emergency department itself. Then the other variant, what we have to know is about submassive PE. So these are the people who are at intermediate risk, may not be at risk in the emergency department, but if you have not identified and treated them aggressively, they will end up in complications. So they will also have any patient with pulmonary embolism with elevated trough or BNP levels, or there is a right ventricular dysfunction in the emergency department on bedside echocardiography, you should have a high index of suspicion and treat them aggressively. So these are the scoring systems, Wells scoring system for pretest probability. I will not get in detail. This is the scoring system where to identify whether the patient is likely to have a pulmonary embolism or not. So the symptoms, what we see is, sorry, I'm struggling with the remote what Naveen has given. Sorry for the jumping of the slides. So in pre-test probability, the signs and symptoms what we look at is about whether the patient has a DVT or suspicion of DVT with leg swelling or pain with palpation is there. And other diagnosis less likely other than pulmonary embolism. So we are shot that this can be a case of pulmonary embolism. The scoring is around 3 and heart rate more than 100. Or if the patient has immobilized for more than 3 days or underwent a surgery in the last 4 weeks, or if the patient has any history of DVT or pulmonary embolism in the past, patient presenting with hemoptysis or history of malignancy. So this is how the scoring is. And if there is a score more than 6, there is a high probability for pulmonary embolism. And between 2 to 6, it is a moderate probability. And less than 2 is a low probability for pulmonary embolism. So this is the Wells scoring system for pulmonary embolism, probability for pulmonary embolism. Then coming to the diagnostic modalities. So far we have seen what pulmonary embolism is, what are the clinical features, what is the pathophysiology of pulmonary embolism and different types of pulmonary embolism. Now we'll spend little time on the diagnosing modalities, what are the diagnostic texts that are available and how do we interpret them. So we know the most common thing what we order from emergency department is ABG, D-dimers. See what are the probabilities of these tests. So D-dimer test, it's a fibrin split product, circulating half-life of 4 to 6 hours. Positive, we call it as positive if it is more than 500 nanogram, and quantitative test of D-dimer has 80 to 85% sensitivity and 93 to 100% of negative predictive value. So these tests have more of a negative predictive value, and these tests are also false positive in many conditions like malignancy, pregnancy, advancing age, sepsis, hemorrhage, etc. So a raised D-dimer cannot help us to diagnose pulmonary embolism, but a normal D-dimer can help us to say that this may not be a case of pulmonary embolism. That is called as negative predictive value. Next is ABG. The most common finding we find on ABG is hypoxia. There can be a hypocarbia also, but this does not have a diagnostic utility in the pulmonary embolism. So when there is an unexplained hypoxemia, you can have a suspicion of PTE in these cases. There are other few investigations which will help us with a high negative predictive value or troponin and BNPs. An increased troponin helps us to understand this patient is going in for RV ischemia or RV necrosis as set in. And once there is a raised troponin or raised BNP levels, that means that the patient is having an increased risk of complications. So I already explained that any patient with raised troponin or BNP, they fall in the category of submassive PE, which makes them to be aggressively treated. And once there is a raised BNP and raised troponin, there is an increased chance of mortality and complications in these patients. Coming to the ECG findings, the most common ECG findings whenever we speak about PTE are S1Q3T3 pattern, which is seen in patients most commonly described by many textbooks, but in general practice, what you will see is around 20 to 30% cases alone. What are the other findings? Non-specific tachycardia or non-specific STT changes can be seen, or ST elevation in AVR can give a clue that this can be PE. T inversions in V1 to V4 is another possibility. And acute cor pulmonale or right strain patterns like tall peak T waves in lead 2 or right axis deviation or right bundle branch blocks are the usual ECG findings we find in pulmonary embolism. There can be an atrial fibrillation or atrial flutter also. Then chest X-ray findings, there will be few signs that we need to know about when we are talking about pulmonary embolism. There is a cutoff sign or focal oligemia of the lung parenchyma. We call it as Westermarck sign. That is first thing. Then there is a peripheral wedge-shaped density above the diaphragm because of pulmonary infarct, that is called as Hampton's hump, which you can see in the peripheries. Then Pallas sign is an enlarged right descending pulmonary artery, which leads to a Pallas sign. So these are the three important chest X-ray findings we need to remember of: Westermarck sign, Hampton's hump, and Pallas sign. Then the next common modality is a venous ultrasound, where we look for loss of vein compressibility. So whenever you are seeing the vein in a longitudinal or a cross-sectional view, if you are seeing a focal gray area in the inside, the blood should look black, anechoic. If there is any thrombus, it appears as grayish or hypoechoic shadow. And if you are trying to compress the vein, if it is blood, you should be able to compress wall to wall in the ultrasound. If you are not able to find the compressibility, if you are not able to compress the vein fully, that means there is some obstruction in the vessel, which is not allowing the walls to collapse with the external pressure. So half of the patients with PE have no imaging evidence of DVT, but still you need to do check for any DVT in the case patients. Then the next common diagnostic modality is echocardiograph. So the most important and can be done bedside is echocardiography, and you need to know what exactly you need to see on the bedside echocardiography. So half of the patients in the emergency room with pulmonary embolism can have a normal echocardiograph. There can be signs and symptoms in each view. We will go one by one. So the first one is apical 4-chamber view. Whenever you see the apical 4-chamber view, the right ventricle will be in the acute angle. So if you see from the interventricular septum to the free wall of the right ventricle, the angle formed between these two walls is an acute angle. That means it is less than 90 degrees. Whenever there is a right ventricular strain or right ventricular dilatation, the free wall moves outside and the angle becomes obtuse. So that is one clue that you will find that there is a right ventricular dilatation in these patients. Then the next thing what you need to look at is the ratio between the right ventricle and the left ventricle. So as we all know, the left ventricular pressures are higher than the right ventricular pressures. The left ventricular diameter is more than that of the right ventricular diameter. So if the right ventricle to left ventricle diameter of less than 0.9 is normal. If the diameter is more than 1, that gives a clue that there is a right ventricular strain or right ventricular dilatation. So what happens? So this gives us a clue that there is the evidence of pulmonary hypertension in these cases. So the next thing what you need to see is McConnell's sign. I don't know if I can play the video. So in this, what you will see is there is a sparing of the apical interventricular septum with akinesia or regional wall motion abnormality of the interventricular septum. So the interventricular septum will not move except the apical area, and the movement of the apex of the interventricular septum gives a feeling that it is a McConnell's sign. So the free wall movement of the apical interventricular septum is seen on the longitudinal view of the 4-chamber view. Next is the D sign, which you will see in the parasternal short axis view when you are seeing the two ventricles in the parasternal short axis. Because there is a more pressure on the right ventricle, the interventricular septum flattens out and gives a shape of D to the left ventricle. The pressure of the left ventricle decreases and the pressure of right ventricle increases, and interventricular septum is pushed in a flat shape, which gives the shape of the D. So you can see it over here. Then comes your CT chest, which is a principal imaging test which we can use to identify any abnormalities of pulmonary fibrosis or pulmonary hypoxemia. Oligemias can be seen on the CT chest, and alternative diagnosis or differentials you need to look at are the pneumonia or emphysema or pulmonary fibrosis of any cause. After CT chest, we can try for MRI modality. The other thing is VQ scan. We call it as a gold standard for diagnosing pulmonary embolism. In this, we will give a radioactive substance to be inhaled into the air spaces of the lung, and simultaneously we give a radioactive substance injected into the vein. So when these two interact, in normal lungs, they look absolutely fine. When there is a mismatch is there, you may not able to see the lung contour properly. So this is what will help us to identify the abnormalities of VQ scan. So this is how a normal VQ scan looks at. The lung contour is maintained when there is no ventilation perfusion mismatch. So this is the anterior perfusion, posterior perfusion, and these are the left and right perfusions. Like this, you can see in all the lung fields. Whenever there is a VQ mismatch is there, either there is an obstruction because of pulmonary embolism, the arterial blood supplied contrast cannot reach the lung fields properly, and this causes a disturbed images like this. Then MRI, contrast enhanced MRI, will help us to identify the findings of the CT scan, and it also helps us to identify the right ventricular function as well. If there is any right ventricular ischemia or necrosis happening, can be picked up from the MRI contrast. Then the gold standard again is pulmonary angiogram, and this will help us to identify emboli as small as 1 to 2 millimeters. And this is reserved for those people where the CT scans are not adequate enough to identify embolism, and those patients who are undergoing an interventional procedures through interventional radiologists, identifying an emboli is very, very important. So this is gold standard in identifying the embolus. So this is how the arrow indicates cutoff of the pulmonary artery. So gives us rise to suspicion that there could be an embolism there. So this is about the diagnostic modalities, and how do we treat these patients in the emergency room? Most important, and most of these patients require supplemental oxygen. Usually high flow oxygen should be given. It is better that we avoid CPAP, BiPAP, or any positive pressure ventilations in the emergency room for these patients, because it decreases the preload, increases afterload, and the hemodynamics can be worsened very fast. And if the airway is not protected, an experienced person should be the one who has to do intubation in these patients, because these people have very low oxygen reserves, and their hemodynamics worsen very fast. Whenever you have to give fluid resuscitation, a small aliquots to be given instead of a continuous bolus in these patients. And if there is a requirement for vasopressors, norepinephrine will be the choice of vasopressor in these patients. Then anticoagulation is a gold standard for these patients, and usually unfractionated heparin is used in these cases, given as 80 units per kg bolus followed by 18 units per kg per hour. The target is to maintain APTT of 1.5 to 2 times of normal. 6-hourly APTTs has to be monitored in these patients to titrate the infusion rates. How does heparin act? It prevents propagation of clot, and enhancement of the clot is stopped by heparin and inhibits new clot formation because of anticoagulation. Even though it is a passive process, it allows body to reabsorb the formed clot and it does not cause clot lysis. Thrombolysis does not happen with heparin, but new clot formation is prevented by using heparin. Then the treatment of choice is fibrinolytics. Alteplase is the drug of choice. Where do we give alteplase? In massive pulmonary embolism or patients presenting in cardiac arrest or the patient having persistent hypotension or patients of shock. These are the people whom we give fibrinolytics in the emergency department. What does it cause? It reverses the right ventricular failure. It increases pulmonary perfusion and improves hemodynamics of the patients who has hypotension. How do we give? If the patient is having pulse, we give 10 mg of alteplase IV bolus followed by 90 mg of alteplase over 2 hours. If the patient is in cardiac arrest, we give alteplase of 50 mg as IV bolus followed by, we should continue CPR for minimum of 30 minutes before we say there is no response to fibrinolytics for PE in cardiac arrest. So 50 mg of alteplase IV bolus followed by 30 minutes of CPR has to be done. Then other interventional procedures are usage of IVC filters. This is mostly for those who are prone for recurrent DVTs which causes pulmonary embolism. IVC filters can be used along with anticoagulation. If the anticoagulation has failed, IVC filters can be of help. The next thing is embolectomy of pulmonary thrombus. It's done by interventional radiologists, indicated in patients who are at risk of bleeding by using thrombolysis. Either this can be done by surgical or catheter embolectomies can be done, where a catheter is passed into the pulmonary arteries and the lysis of the clot is done and retrieved from the catheter. Then regular prophylaxis for prevention of thromboembolism. For all high-risk general surgeries, unfractionated heparin or low molecular weight heparin should be given within 24 hours of surgery. And most of the cases has to be treated along with, if there is a prolonged bedridden state, we have to give them graduated compression stockings or IPCs can be given along with low molecular weight heparins, and it has to be weighed between the risk of bleeding versus prevention of pulmonary embolism. Then to summarize, more than 50% patients of DVT has a pulmonary embolism, and 50% of cases may not have any signs and symptoms of pulmonary embolism in them. And unexplained tachycardia, hypoxia, and tachypnea are the common presentation of the patients with pulmonary embolism. And the diagnosis and suspicion is purely clinical. Follow-up with anticoagulants is a must, as there is an increased risk of recurrence. So even if we give fibrinolytics in the emergency department, we have to continue them on anticoagulants and may need a prolonged course of anticoagulants in these patients. So to summarize, prevention is better than cure, and we should always have a high index of suspicion for any bedridden patients or prolonged immobilization. The risk of PTE has to be considered, and we have to take appropriate preventive measures in these patients. Thank you. You can take some questions if any questions are there.
Pawan?
One moment, sir. Sir, any questions?
Yes. Saujanya ma'am.
Yeah, I'm seeing the questions. Just going.
Thank you very much, ma'am. That was an excellent and elaborative and wonderful talk, undoubtedly. So it really is my bottom of the heart. It is our privilege to have you here. Thank you so much, ma'am, for accepting our invitation, for being here, for spending your time. I know how busy you are. So despite all these things, you are here for today. Thank you so much, ma'am. So there are few questions, ma'am. Can we take up the questions, ma'am?
Yes, please.
Yeah, first one. So patient is in cardiac arrest. So how to diagnose? It might be because of PTA. If using in cardiac arrest, doesn't interrupt CPR. So can I take this question, ma'am?
Yes, please.
Yes. The question, yes, KB, someone, I don't know exact his name. So there are few studies using of echocardiography during CPR, like a field focus echocardiography in life saving. It is already authorized and suggested by the UK Registration Council. But only thing is we have to do echocardiography while we are checking for the pulse. We have to do echo within the 10 seconds. It should be limited to 10 seconds only. So anyhow, when you are interrupting the CPR to check the pulse, to check the rhythm, during that time only you have to utilize echocardiography to look for the reversible cause of the cardiac arrest. So that is one of the UK studies. Then another one is another concept like focus, what we are doing point of care ultrasound. So new thing has been added to this, focus CA. CA means cardiac arrest, focus CA. So there are many studies right from last 4 to 5 years. So in that they have mentioned many things like views. What are the views when we are doing the CPR? So regarding the view, it should be like a subjectified view, so that it will not interpret the CPR. So then we can see the interventions, then effectiveness of CPR, then the outcomes of the interventions. So when we do the echocardiography during CPR, so that is one thing. It is also mentioned that it is useful only for the non-shockable rhythms like a PE and asystoles, not for the shockable rhythms. So they are doing many studies on shockable rhythms. Still, it is even today it is research are going on, but they have given the promising results only for the non-shockable rhythms like PE and asystoles. So I think my answer might be right. So what do you say, Sajana ma'am?
I agree with you. And the one clue that you should look for when you are doing echo in a cardiac arrest patient is that subxiphoid view where your right ventricular diameter is more than that of left ventricle. That gives a clue. And as I mentioned, pulmonary embolism is purely a clinical suspicion, and diagnosis is also by suspicion. When you have all doors closed with a cardiac arrest, there is nothing harm in giving one thrombolytic agent for these patients. It can give them a benefit.
Benefit, yes, exactly. Then another question. So what's the gold standard test for PTE?
CT pulmonary angiogram.
CT pulmonary angiogram, yes. Then another question.
That's the same thing, I think, repeated.
Yes. So other than Wells criteria, is there any other new criteria for PTE?
There are BOA scoring and pulmonary embolism risk stratifying scorings are there, which will take into consideration of hypotension, tachycardia, elevation of troponin and all. Again, that will help us in differentiating between massive and submassive pulmonary embolisms.
Yes. Then another question, role of MR angiography.
Role of MR angiography, again, it will help in identifying the pulmonary embolism and also help us in giving right ventricular functionality as well. Yes.
So regarding this imaging techniques, there is a study. Actually, I have asked in the quiz session as well, PIOPED study. So it's like a PIOPED 1, PIOPED 2, PIOPED 3. In the PIOPED 1, they mention, so they focus more on the scintigraphy, VQ perfusion. Then when it comes to PIOPED 2, they focus more on the CTPA, CT pulmonary angio. So in the study also, they mentioned that CTPA alone is not enough to confirm the diagnosis of PTE. You need to do the CTPV as well. Then PIOPED 3, this is one of the recent study where they focused more on the MR, so magnetic resonance images. So they are telling that MRPA plus MRA-PV to be done. So not MRPA alone. So that's one of the recent study which is published in the year of 2020, I think exactly. They are going more towards the MR because of radiation and all these things. So where we cannot perform the CTPA, there we can go for the MRPA as well. So actually I asked the same question or in the quiz session. Then one more question, role of copeptine in the PTA diagnosis. Can I take this question, ma'am?
Yes.
So copeptine, it is like one of the indicator. So when there is a stress and vasopressin will be released. So this is copeptine is nothing but is surrogate marker for vasopressin. So there are many studies which are undergoing now. So a few of the studies have been published already on copeptine. So but we don't have the facility to do the copeptine levels. But this is one of the reliable surrogate indicator for PTE. Then we can take the last question, I think, ma'am. Majority of the questions are repeated.
Other than Wells criteria, I think we answered that question.
So that's it, ma'am. Those are the major questions.
There's one on chart box. Can we thrombolize for submassive pulmonary thromboembolism?
Yes, ma'am. Can we thrombolize for submassive pulmonary thromboembolism?
Submassive pulmonary embolism, again, we have to weigh the risks. If there is any right ventricular dysfunction is there and patient is going in for requirement of high node probes, we can always go ahead. And if there is any elevated trop and BNP levels, that gives us a clue where these patients needs aggressive treatment. And aggressive treatment, when we say it is again about submassive pulmonary embolism. So the dose of alteplase is 10 mg IV bolus followed by 90 mg over 2 hours.
Yes, ma'am.
Yeah.
Then there is one more question, ma'am. Post PE syndrome. I think I can take this question, ma'am.
Yes.
So this kind of syndrome can be seen after patient being affected from PE, pulmonary thromboembolism. So symptoms are like chronic fatigue and dyspnea, then excess intolerance, and then low perception of being healthy. So these are the things which can be seen after they're being affected from the PE. So a percentage about 5 to 10% where we can see it. Then sometimes we can see like a portal hypotension as well, ma'am. Portal hypertension as well, secondary to the PE. So I think we have done with our questions, ma'am.
Yeah, sure. Thank you.
Yeah. So thank you, ma'am. Thank you so much.
Thank you.
Thank you so much for being here. So I thank all the viewers on behalf of Yashoda Group of Hospital. Thank you, and all. We will catch up in the next session. Thank you all.